All right. Let's see. Ed, do you want to introduce yourself?
Yeah, you bet. Thanks, Will. Good morning, everybody. Ed Kaiser here. I'm a family training nurse practitioner in Omaha, Nebraska. Excited to be with you guys. Been working with substance use disorder for the last 7 years. Recently launched an online platform to help people with alcohol use in Nebraska and Iowa. So I'm excited about that as well. But thanks for letting me be with you guys.
Thanks, Ed. And John?
Morning. I'm John Massey. I'm an interventional pain physician in Lincoln, lots of other places, and treat a lot of people with comorbid pain conditions and substance use.
Thank you. And Todd?
Good morning. Todd Stoll. I'm a psychiatrist. Thanks for joining, everybody.
Thanks. And let's see. I'll have you go next, Alex.
Thanks, Will. Alex Dworak, board certified family physician with an interest in substance use and infectious diseases. Appreciate everybody being here.
Thank you. All right. And then Stephanie, I'll let you introduce yourself and start us off with the first set of cases.
Hi, everybody. I'm Stephanie Bennington. I'm a psychiatrist. Kind of move around a lot right now. I'm in Gillette, Wyoming, going to Rapid City and Chadron area here shortly. So I kind of seem to get bored and then jump around, but was previously in Omaha prior to that. If you guys give me a minute, I had to restart my PowerPoint to pull this up. So bear with me. Okay. Is it sharing the screen?
I don't see it yet.
Okay, let me try this again.
There, now I can see it now.
Okay. Okay. So today we're going to do case studies really to try to get, those kind of scenarios that we all encounter. And it's like, what do I do at this point? These are the cases. These are the ones particularly that I'm going to present today. The first one will involve ADHD. That's one of my passions. That's a diagnosis that I enjoy treating, particularly because there's a lot of substance use with it. And if you're able to treat the underlying issues, typically it makes the treatment for the substance use much more manageable and much more successful. So I'll kind of spend most of the time discussing that case, kind of try to give you the typical scenario of patients walking into an outpatient clinic is how I tried to design this. And then the second case, I'm going to just touch on it, something that's kind of newer, but I'm sure a lot of you guys have seen both in the hospital and outside of the hospital is kratom use, which it's not controlled, can essentially get it anywhere. Comes with a lot of problems and a lot of substance use associated with it as well. And then after that, then I will let Alex take over and he will present his interesting cases. So the first case, and I apologize if some of this is kind of packed, some of the slides, the text might be a little packed, the formatting's off, but I'll make sure these get sent out to you guys so you have the information. But the first study is a patient that I have been seeing for a while. MK, 32-year-old male, only history, only psychiatric history was he was diagnosed with ADHD at age 9. Thinking back to some of the statements that he was told, it's like he's just a difficult kid. If you just try harder, then generally it will be easier for you. Very difficult time at school and at home, both required for the diagnosis. But he ended up he does not believe he received any treatment, any medication at any time. His parents, I think he grew up primarily with his mother, did not believe in ADHD treatment, thought it was just a way to silence the kids. So he actually never ended up going on any medication. He ended up dropping out of high school. He was a sophomore, went kind of right into the workforce, kind of dabbled in various substances, but ultimately he was able to obtain his GED. I think it was about, from when I saw him, it was about 8 years prior. So in his 20s, he was able to get it. The main thing that he presented prior to kind of talking about the opioids was he really touched on his chronic history of not being able to maintain employment. This started from his very first job. He said he would get fired and would admit fault for all of those issues that were brought forward. Never had an issue with getting along with anybody. A lot of it had to do with forgetting he had to work, showing up late, his alarm. He had like, I remember he showed me his phone. He had like 10 snooze alarms. So I commonly ask patients to show me their alarms or show me how many unread text messages or emails or things like that. And it's always patients always laugh because they feel called out for it. But kind of walked me through this very difficult path that he's had, but still it managed to get to where he was today, currently holding down a job. When he came to my office, he was currently preparing for an electrician exam. He had tried it about 6 months prior, failed it, and was having a ton of anxiety associated with this repeat, and worried that he was going to fail because ultimately he would not be able to stay with his employer. So medical history, the only diagnosis he's ever really had is he's had chronic pain since age 24. He had like a construction type injury on the job. And ever since then, he was prescribed hydrocodone that's gradually increased over the years. And now he was currently taking about 10 milligrams, 4 to 6 for about the last 5 years. And he was consistent. He said he would take it 3 to 4 times a day, would often run out of the prescription. Pain management plan had been discontinued by his PCP, which is kind of where he was at. He was on his last refill, got notice that it was not going to be refilled that point forward, which is where he kind of ended up in my office. That wasn't 10 months prior. That was supposed to be 10 days prior. So this was relatively recent than when he saw me, and then he made the initiative to do something different. With this particular patient, I will say, I'm going to kind of backtrack. Sorry, I'm kind of jumping all over here, but with this particular patient, it took a little time to actually really discuss the opioid use, which is typical for patients. By the time they end up getting to psychiatry, they there's a lot of stigma. There's a lot of negative feelings that they have felt from the healthcare industry in general, with nurses, physicians, nurse practitioners, even down to anybody that's working in a clinic. There's just this negative stigma that he's felt, and is certainly there. And because of that, even getting to an environment where it is communication is okay, we can talk about it freely. It takes a lot for patients to actually disclose and really talk about it freely, because they kind of immediately want to defend the opioid or defend their pain. And that's one thing that I won't ask a patient to do. I will take, the pain as that's painful, and that we're at this point. So it did take some time to kind of break this patient's wall down to get him to talk about it. He didn't disclose that he was going to run out initially in that first visit. Really, he wasn't in kind of the stage of change. He was kind of more in the contemplation, kind of like, what are my options here? It was about, I think, this 6 visit. He was inconsistent in the beginning, then became much more consistent. Is then when he fully disclosed. And when he disclosed kind of his path, it all came out. He was an open book. He was really struggling, and at that point, he was well into actually making changes and regarding the substance use. So kind of going back to where I'm at with this, what he ended up doing on his own is his primary care provider did end up stopping the opioids. He didn't end up going to get a different primary care. He saw pain clinic, but it wasn't successful, still continuing to have pain. And then started using fentanyl pills in the community. He was never sure how much he was taking. Sometimes he said, I take like 4 pills, but even that doesn't control my pain. Sometimes I take 2. It was very unreliable. Never had to go to the hospital for any overdose, never had to have Narcan administered. And so he was always he would try to find what his limit was, although that's not a reliable way, right? Fentanyl is very, very deadly and easy to overdose on. By the time we started talking about the opioid, his main focus actually still wasn't the fentanyl use. The primary complaints during the visit were the cognitive struggles, things like that, which is why we ended up getting to the point at the 6-month mark is when he was actually interested in treatment, and still not necessarily ADHD treatment. He really didn't know there's a treatment at that point, just wanting to know this is not the life that I want. This is not what I'm going to do. I put some of his quotes down because it really resonated with me when he ended up making these statements, because these are things that everybody has heard in some way, shape, or form. And you guys can read it, but I'll kind of touch on the ones that I feel like he really spoke for all patients that have been in that situation. One of the statements was, they help a little, I can go to work. So he's trying to bargain, like trying to find a positive in his scenario, because we have to have something to keep us going, or else if there's nothing, that's, depression, suicidality kind of takes over. Again, the main complaint was the test. It wasn't the fact that we were taking so much of the fentanyl. It wasn't the fact that the pain, it was, I just can't study. Kind of going back, to his prior diagnosis of ADHD. Concerned about school, concerned about job. One of the main statements was that I always appreciate when patients say this is, I'm not trying to get high. Because they commonly will say this across either the ED, outpatient, and people kind of blow it off as, I hear it all the time. That's what they all say. They just want the pills. And this is a difficult thing to say with these patients, because substance use individuals, people with substance use are actually quite honest individuals. They're kind of an open book. They want to disclose everything. They want to have somebody kind of share that with and navigate with, because it's incredibly scary. And it's incredibly sad and makes patients feel very alone. So by the time they end up coming to the ED, I mean, they're at a point that they have no other options, that's their option. And so then they kind of get met with this wall and not feeling like they're believed, or just kind of, drug seeking or frequent flyer. And he kind of gave a rationale of that he'd been high before, kind of again trying to show me that he's trying to give me honesty, trying to give me everything that I need, and essentially to not shame him and not to make him feel bad for this, because he already feels bad enough. And so this ultimate reason, when he ended up coming back to that visit, his ultimate question or ultimate goal wasn't necessarily to go on a different medication or go on medication for ADHD. It was solely to help him with the sickness, the withdrawal effects of opioids. And this is something that I'm sure everybody could relate to. It when patients describe it, they describe it essentially as feeling like they're dying. There should be, let me check here. So I'll just kind of discuss with him what we ended up doing. There should have been another slide. I'll have to add that back in. But what we ended up doing for him is, we have two conditions that both equally need to be treated. And this is where the conundrum happens. When somebody with substance use, somebody is at high risk of relapse when they come off, high risk of not maintaining compliance on the treatment. There's this concern that, well, I don't want to give them another controlled substance, because essentially I would be putting myself at risk, patient at risk. And so that's not a good option. And so it gets into this bargaining of treatment. Which one's worse? And that's the one I'm going to treat. And that's when it comes to ADHD specifically. This is a condition that absolutely has to have treatment. You're unable to fully treat the substance use. It could be opioids. It could be a methamphetamine. It could really be anything in this. If it's multiple substances, then we take one at a time and we treat one individually. But the whole plan should always involve treatment of the ADHD. That has to happen in order for everything else to happen. Because ultimately, we may not have got to this point if the ADHD was treated at any point in his life. Now, whether or not this would have happened, it's unsure, right? It depends on his specific characteristics. However, his risk would have been lower. So when looking at ADHD and the opioid use disorder, one has to be started first, and then the other condition must be treated shortly after. And I explained this to him. So we ended up starting with Suboxone. Started him actually on 8 milligrams. We kind of went to a higher dose. Waited 12 hours before we initiated treatment. He was comfortable initiating, and I was comfortable. We tend to have about 2 sessions explaining this on an outpatient level. But he was comfortable initiating it on a Sunday, so that he could come into the clinic on Monday and I could reassess his symptoms. So he started at 8 milligrams and then gave him 4 milligrams, 2 different doses of 4 milligrams Suboxone strips that he could take as needed on that Sunday and then before seeing me on Monday. When he came on Monday, he had the 8 milligrams in the morning, and then he only needed 1 of the PRNs. So he was at 12 milligrams. And so that's the dose that we went with on day 2. And that's the dose we ended up maintaining on his treatment. After day 7 that he was stable on this, typically it takes about a couple days to actually titrate that dose, but we waited 7 just to make sure that he was able to acclimate to Suboxone and not confusing any potential side effects. We went to initiating Vyvanse. And this was one that I actually had to talk him into because of that stigma associated with ADHD, and that, he led his life of believing, if I just try harder, if I just do things different, then I will be able to get the results that I want. And we'll kind of jump back in here now. We had lengthy discussions on the medications. He asked for printouts to kind of look through it. So he was well interested in his own care, and we were able to make a decision based on that. We think about what are the options with ADHD. Stimulants or non-stimulants. And I've heard a lot of providers say, well, I'd be more comfortable with non-stimulants because, he's already on a controlled substance, or he has a history of misuse. I don't want to put that risk. It's already too high. I'm not gonna take on more risk. But when we think about medication, we have to think about which one is first line and which one is more effective. And I listed the study that looked at specifically this in ADHD treatment, but there's a reason that stimulants are first line. The meta-analysis I looked at was about 70 to 80% response rate with stimulants versus 30 to 40% for non-stimulants. You guys, this is huge. We don't have anything as successful in medicine as stimulants in ADHD. So we got to give somebody all the tools that we can to treat the condition, especially in somebody that is high risk of relapse, subsequent depression, suicidality. This patient was particularly at a high risk because we could treat the substance use if we are treating the ADHD, we have a better chance of success. With this study and with starting any ADHD medication, long-acting formulation is generally better, more tolerated, but especially so in patients with a history of substance use, where they just have that 1 pill a day, not required to do multiple dosing. Key risks of undertreatment. Some of the things are that we need to be concerned, or why we do them, why providers may be scared or limited in wanting to give more medication, is academic and occupational failure. These are the issues that potentially could expose the patient if you are under treatment. I don't know if anybody's ever been, whoever was in my last, I think it was about a year ago when I did a lecture on this, on looking at under treatment of ADHD versus full treatment. And under treatment of ADHD is actually more dangerous than not treating. And so, I mean, in this particular case, he was at risk of losing his job, failing the exam. He was already secluding himself from family and friends, things like that. Chronic stress and identity dysfunction. And then, of course, he's at an increased risk of relapse, depression, suicidality, as I mentioned. There's always a statement that comes up when I have the discussions with other providers is, if I give them this treatment, am I potentially increasing their risk of relapse? And I don't know where this came from. There's never been any data to support it. I think it's more fear within ourselves, fear that judgment that, our controlled substances are being reviewed by the government. Are they going to look at it and are they going to judge my treatment? Am I not providing appropriate care? Am I going to be able to defend this? But we have the studies to back up that treatment of ADHD individuals with substance use is associated with the reduced substance use and improved retention. The data is consistent on this. It works. It helps patients get off the substances, and it helps to maintain a substance-free life and being able to carry on in society as they would have wanted to do prior to the substances. And of the studies, I also listed the other one that Vyvanse actually improved ADHD symptoms and reduced relapse in amphetamine-dependent patients, which is always an interesting study. This is not reliable as other studies have not been able to also get similar results, but this is a step forward. And we don't have anything to actually treat amphetamines consistently or reliably at this point, but the studies and the results are there. So for the rationale of deciding for this particular patient, what is the best treatment for him? He's a high risk for decompensation, untreated ADHD. His failed goals of failing his test, it increases risk of depression and suicidality. Treating ADHD reduces risk of self-medication. It does not increase it, as the studies have shown. And then there's monitoring strategies that you can do to offset stimulant misuse risk and also, make you feel more comfortable initially. Some of the key takeaways that I always want providers to hear and kind of take away from my lectures associated with ADHD and substance use is trying to change the mindset of patients coming in and either requesting a stimulant or describing symptoms that would render a treatment with a stimulant. We don't want to punish these patients. They've actually been punished a lot in the medical community. So you don't want to be that person that also adds to that kind of trauma, the medical trauma that they've had and how they've internalized this view of themselves with their substance use and their ADHD. ADHD deserves treatment, even in the context of active substance use. Functional support medication, harm reduction are not mutually exclusive. And then treating ADHD may prevent relapse, improve engagement, and transform lives. And a statement that I put at the bottom, he isn't a lost cause, he's a missed opportunity, because the studies show that if patients are treated at an earlier age, particularly in childhood, it does reduce the risk of substance use later on in life. And I kind of listed some of kind of the stigma that I can let you guys read through. I want to make sure that there's enough time that Alex can provide his cases as well. But just as a reminder, ADHD, it's not a behavioral thing, although patients, when they generally come to my office, they generally think it is. If I just try harder, if I'm a little more dedicated to studying, if I, don't procrastinate, if I'm just not as messy, if I stop buying things, life would be easier. But it's not a behavioral effect. It's not defect. It's not something that can just change. It is a neurodevelopmental disorder, and it requires treatment. And the treatment generally substantially improves their life and making life easier to manage on a day-to-day basis. The substance use doesn't eliminate a person's ADHD diagnosis. As much as we maybe try to ignore it, it does not eliminate it. It's still present. And again, start with one treatment to kind of titrate, and then you would add on the second treatment instead of starting them at the same time to avoid potential side effects. And again, delaying or withholding ADHD treatment until full sobriety is not okay. Patients can't be punished for a condition that they didn't want to begin with and that they have no control over. I listed a couple things that you guys can do if you have a patient that presents with those symptoms and the concern is for ADHD and we have active substance use. The typical response that I've seen in providers is sending them for psychological testing. And sure, this can be helpful, but it's not required for diagnosis. This is a clinical diagnosis, and quite honestly, patients can't afford psychological testing unless insurance pays for it. But generally, these patients will have a high deductible. And ADHD, people with ADHD, that's a hard request. That is a hard task to do. because it's another step and they're not being treated, or they're not being treated with medication. So being able to do these steps and exhibit the executive functioning it's tough. So if they're not able to do things at work, the odds of them actually following through on this psychological testing is pretty low. So if we can avoid doing that, and we feel like we're comfortable enough making the clinical diagnosis with a scale, the ones I listed, ASRS is the most common for adults, and what we typically use. Then use that, feel comfortable, provide the documentation, what scale you used, and then the as long as documentation is there with the clinical basis that there was a self-report test done, that's all you need to provide rationale for starting the stimulant. Also, with this patient, CBT ended up being the recommended treatment of choice alongside the stimulant, and actually is very effective for a lot of my patients with ADHD because it's very validating, because they've heard their whole life, you talk too much, you're loud, all the qualities in themselves that they feel are very negative. They've now internalized that, and being able to talk about it as a symptom of ADHD and not themselves is very validating for patients. So it's quite therapeutic. So we generally do that for about 3 to 6 months, and they are successful in the medications. And again, I kind of listed it in kind of an easier format here. Some resources that you guys can look back on if you have any questions. Can certainly always reach out to me. I love treating ADHD and substance use. If there's ever a concern or kind of question with navigating ADHD, please reach out. The second case I'll just kind of go through very quickly here. The second case involves something that we've all seen because it's not controlled. You can get a gas station anywhere. Is kratom. I recently had a very difficult case with this, and I wanted to kind of provide what I ended up doing, and it was successful because we really don't have a lot of data to support what should be done with kratom use in somebody that's chronically using. With this patient, he did have a history of opioid use, 10 years. He was in a car accident. He was on hydrocodone. He kind of similar scenario, misused the prescription. A 4-week supply typically would last him 2 weeks, and it would get refilled early. His primary care provider ended up retiring, and then he just didn't find anybody, which it is more out of embarrassment of how he described it, because of the fact that he was on so much of the medication and was able to get it so early. He didn't want to have to explain that to somebody else. So I ended up just not seeing anybody else. He tried a pain clinic, not successful, and then was told about kratom from a friend of him and friend of his, and said that could essentially prevent the withdrawal symptoms that he was fearful of. And that's where kratom comes in this patient's story. He ended up first starting on just a couple tablets as his patient recommended, his friend of the patient recommended. But started having some withdrawal side effects when he stopped taking the hydrocodone. And then he very quickly increased the amount that he was taking over those years. Been on it for about 10 years by the time I saw him in clinic. And at that point, he was taking about 16 tablets in the morning, 16 to 20 in the PM. And the dose was unclear. No idea. A lot of times don't know. It's not actually listed on the bottle. So I kind of based it on how many tablets they're taking and what their symptoms are if they essentially go like in 2 hours later. And that was how I was kind of able to assess that he would go into withdrawal. Kind of give you just a quick little mechanism of action to kind of explain it. Essentially, at low doses, kratom acts like a stimulant. At high doses, it acts like an opioid. So that's where it can be really successful for managing the opioid withdrawal symptoms when patients come off of it, which is how it's been recommended kind of in the substance use population. And kind of give a little bit more information. Again, this will be emailed out to you guys so you can have. But in his case, so low doses, as I said, has a stimulant effect, is generally 1 to 5 milligrams. 5 to 15 is moderate. Anything above that is more of an opioid-like effect, and that's essentially what he was on. So with him, we planned. He tried multiple times to stop. Tried to go to a pain clinic. Nothing worked, and at that point, this was controlling his life. And so the plan was we're going to stop kratom and we were going to initiate Suboxone. There's about 2 studies that have done something similar and had success with it. I kind of explained that to the patient, but again, there's no approved protocol for this. There's kind of in the dark. It's not FDA controlled, regulated. So we're kind of in the dark on this, but we know he's going to feel very, very crummy if he stops it on his own. So with him, I had him actually come into clinic, waited 12 hours. I think it ended up being 10 hours for him. But came into the clinic and we actually initiated the Suboxone in clinic at 4 milligrams. And then I gave him 3 of the Appearin sublingual strips that he could use at home. I think with him, he ended up taking, and I asked him to cut him in half and just do half. So he essentially had 2. But his dose ended up being 8 milligrams total by day 3. And so that's what he maintained for 6 months and it was off kratom, didn't crave it. He was doing very well. Pain came back, but he was fine with it. He was functioning and able to go back to work at that point. We were able to get him down to 4 milligrams, and then we were going to reassess on what his idea was of treatment long term, if he wanted to stay on it or not. And those are my 2 cases that I wanted to present. If you guys have any questions, I'll have you wait till the end. I'll have Alex now jump on and do his, and then we'll answer all the questions together if that's okay.
All right, I'll get my slide shared here in just a second. Mine are not going to be as detailed, which is probably a good thing. So I have a little bit more of a potpourri here, with one case that's a bit more detailed. So let me get the slideshow going, and we'll get the show on the road. Stephanie, those were awesome. That I've had that exact situation happen more than once, and I've also evolved from like, oh, go get an eval to being more welcoming and recognizing the barriers patients face. So I've loved ones with ADHD, so I appreciate your advocacy for people like that. So for my
Thank you.
slides, these will be kind of some quick hits. I had planned to encourage people to jump in the chat with your thoughts on a few of them, so we'll see if we can do that. And again, I don't have any disclosures except that Purdue Pharma drug reps told me how amazing OxyContin was when I was in training, and so I'm very meaningful for me to get to be here, trying to make things better for patients instead of worse. All right, so first case, 36-year-old former D1 athlete moved back to her family farm and tells you that after some sports injuries, she became dependent on painkillers. Eventually, as legislative and policy situations changed, she went to heroin because she couldn't get OxyContin anymore, and she now thinks she's getting fentanyl. She's seen test strip stuff online, but hasn't gotten it, so she's not sure. But Narcan by her family twice, and she has a lot of shame. She has been physically yelled at by locums who accused her of not trying and having bad moral character, and was not sure where to go. But you treat her cousin, and the cousin said, "Go see such and such. They're kind and they'll take good care of you." And you're maybe somewhere around Alliance, I don't know, but Omaha's a long way away, and it's also a bad time to be away from the farm to either take a trip or to consider some residential stuff. She feels like she's in withdrawal right now. And then my nurse would actually send me a secure text or maybe like a perfect serve, but well, the nurse knocks on the door and hands you a note, HCG is positive. So what should we do? Anybody either can unmute or if you want to put in the chat, what would you recommend in terms of medication assisted treatment in the context of a pregnancy? Hopefully everyone's had their coffee before the interactive part of the presentation here. Text? Okay, that's a great point. So we'll talk about that. And in the interest of time, not seeing anything else, Brooke, thank you for being the sacrificial volunteer and jumping in the chat. So, my recommendation, and I didn't think about the subtext, but we can talk about that. This was a quote from somebody from Kearney. 88 of 93 counties meet criteria to be considered underserved for mental health, and then addiction treatment, probably like all of them. And then rural, so in all the flap about different populations and equity and other such things, it's important, I think, to remember that rural populations are underserved and they're an equity group. And I think that as a mostly rural state, which is Omaha, Lincoln, and Greater Nebraska, basically. Policymakers would do well to remember this, especially ones who represent these districts, but they seem to be really bad at that, in my personal opinion. Um, doing some medication-assisted treatment is absolutely the right thing to do. Brooke is very correct. We should either be giving buprenorphine or methadone, and for most folks, especially out in Greater Nebraska, driving to a methadone opioid treatment program once a day at like 6 in the morning is just not feasible. In a different way than like, oh, take your executive dysfunction and go get a very grueling test arranged, and then come back, and then we'll think about treating you. Saying, oh, go to a methadone clinic. Is, some people absolutely need that, but for many folks, that's just not feasible. I think that could be a little bit of punishments in that, like, you can't have treatment unless you go do this thing that you clearly can't do. Kind of the labors of Hercules kind of a thing. And we should offer as many options as possible, but for most folks, especially outside Omaha and Lincoln, buprenorphine in the office is going to be the best thing to do. We can all provide this, and I think we all should. And There's data that there's less chance of neonatal abstinence syndrome. It's still good to have a discussion with your high-risk OBs, which is often going to be done via teleconsult or maybe a one-time trip for people who are delivering in rural areas when you're not in a maternity care desert that has no obstetric capability, which is another policymaker focus that needs action across our great state. Um, the question about Subutex versus Suboxone, i.e., buprenorphine alone versus buprenorphine naloxone, that has been looked at. I failed to put that in my slides, but I will get that. There's been some research that shows that buprenorphine naloxone is actually quite safe in pregnancy, and it also has less of the diversion or misuse capability. So that was it's a bit of an older thought that we need to do just buprenorphine in pregnancy. We can actually use the same medicine for everyone else. That it can be nice, and you rarely have someone say like, "Oh, I get a headache from the naloxone. I just need a pure buprenorphine, please." Uh, this is what we can offer here. Please, let's work together on that. So, okay. All right. Well, and then again, thank you very much, Brooke, for jumping in. You win nothing. You win eternal fame and fortune not guaranteed. So, all right, so your next patient is a 45-year-old veteran with alcohol use disorder who served in Afghanistan in a combat role. He reports he discharged honorably and tried to get back into civilian life, but he has troubling, intrusive memories of friends and Afghani combatants and civilians, some of whom he became very close to, suffering IED and other combat injuries. So this is pretty consistent with PTSD. And again, veterans also an equity group. Like they have much higher rates of many things, including PTSD. They face unique challenges, and they are not understood by civilians like me who haven't had those experiences. So um, he was in Omaha, but then he moved out to a rural area to be close to family. He did attend some AA programs, but he's not theistic. That's another equity group where many of these programs are very faith-based. And so if you share the faith of the people there, I have patients who really swear by that and find it very helpful. There's also multiple anecdotes I am aware of where people found that actively unhelpful because it's using language that doesn't apply to them. And that's kind of a theme in the cases I've looked at where when you are excluded and minority stress is added to you, you tend to not do as good. Um, that said, he would like to have mats for alcohol. He is still drinking. And then you look at his liver enzymes, and they're not horrible, but they're elevated. AST to ALT elevated in the mythical 2-to-1 ratio. So he does not have normal LFTs. All right, so audience participation again. What would you recommend? Naltrexone, disulfiram, acamprosate, or baclofen? What has the best evidence for effectiveness and safety in this context of some component of active hepatitis? Well, I forgot to look up a YouTube video of the Jeopardy music. I don't know if you want to play that for us in the background.
If I had some on hand, I'd play it too. Yeah, we can We can do
Thank you. We're
you
getting in. So C, that's a good thought. Not okay. Now we got a ringer in the chat saying naltrexone. Okay, fight, fight, fight. All right. So and we'll talk about the subtleties here. These are things that I still have to look up. So unlike Ed, I do not have this all in the little imaginary Rolodex in my head. When somebody has advanced liver disease and is already not drinking, acamprosate has some good data for maintaining sobriety. Yep, we're seeing some more people jump in here. And then I found this citation, and I don't know if everyone else here knows Alona Balasanova. She is a fellow UNMC teacher, recent winner of the NMA Young Physician of the Year. Really inspiring personal story and awesome teaching and research. And I'm like, oh, I know that nerd. I'm going to cite her paper here. If someone is still drinking, naltrexone helps reduce heavy drinking, as we know. I have had patients where I literally explained that it is not disulfiram and it's not going to make them puke, and then they came back and they didn't take it because like, well, it was going to make me puke, and I'm like, we literally talked about that. With this little handy dandy chart here, it shows some of the differences. Disulfiram is an aversive, and if I remember right, it inhibits formaldehyde dehydrogenase. I think it just makes you really sick. Um, this in some of the cases and lecture sessions I've attended over the years may be helpful for like flight status people like pilots or maybe medical professionals who are very capable and also very highly motivated because they stand to lose a lot. The psychiatrists could probably speak to that a little bit better, but for most folks, it's not going to be your best bet. And naltrexone does have the best evidence. Acamprosate requires more frequent dosing, but it can be more helpful in somebody who has advanced liver disease and, again, to maintain sobriety in someone who's already stopped. But with all these things, I think that this naltrexone would be probably our best option here. And I've tried to include the links to back up everything I'm saying here because these people are all smarter than me about this. Okay, the point about the elevated LFTs, this came up for me in clinic with one of my teammates last week, and they thought like, can't we like, isn't naltrexone going to like make your liver worse? And it's like, well, having elevated LFTs in the presence of active alcohol abuse is kind of like having some substance misuse in the presence of untreated ADHD. Like that's gonna happen all the time. But this article highlights naltrexone is safe to use in people with underlying liver disease, including those with compensated cirrhosis. If someone has decompensated cirrhosis, you may be thinking acamprosate, but they also need to be seeing a liver specialist to be evaluated for liver transplant. That person is really, really, really sick. And if they're rural and far away from resources, we need to figure out how to get them resources before they exit stage right from this mortal coil. And then naltrexone talks about a bit of its mechanism with moderating dopamine surges. Again, it has superior efficacy compared to both baclofen and acamprosate. Unless someone has very advanced liver disease or they are also on chronic opioids, usually naltrexone should be our first choice, in my opinion. Okay, and now another one. A patient is a 55-year-old Lakota Native American woman who has a past history of alcohol, marijuana, and stimulant use. And she is in recovery, and she has well-controlled high blood pressure. She does not live close to an Indian health service center, and so even if you are totes not native, she feels comfortable talking to you. This is kind of a composite of real people that I see. And then this is less about medication choices and more just something that I found as I was trying to look at different statistics. Historical trauma is a real thing and can compound with other social determinants of health and is a factor in the higher rates of substance use faced by many marginalized groups. This really was kind of thought-provoking for me, and I think we'll just keep plowing ahead on this one because it's a bit of a guess what I'm thinking or what this paper said. If someone is trying to have successful recovery from substances, this is a paper that looked at different factors of how much historical trauma symptoms are they feeling? Are they feeling current trauma symptoms? Are they aware of systemic discrimination? I think of this when my family vacations in Minnesota in the summers. We see lots of, resorts and other places, where people who look like me are vacationing. And then we drive past reservations and other areas that are farther from the lakes and very visibly in poverty where people who do not look like me live. And it's like, that's in Minnesota, it's mostly Ojibwe, but again, that's a real thing. So are people aware of what's going on, and how strong is their ethnic identity? Like how connected do they feel to their roots, to their past? And so this talked about are they thinking about what's going on that's affected their people with historical trauma? And actually, those being aware of those thoughts was associated with more abstinence and less heavy use. And if somebody is focusing on that, if their historical trauma symptoms are low, like so if they're aware of it, but they're not feeling or being reminded of it constantly. Current trauma symptoms are low. That makes sense. More trauma is likely to lead to more self-medication with substances. If they're more aware of systemic discrimination and if their ethnic identity or connection to their roots are both high, they tend to do better. So, again, that's not necessarily something that we can treat with a pill. I think that is something that we can be aware of in interacting with any Native folks who seek care with us. And also, as we think about our advocacy interactions and different policy initiatives in Nebraska, as well as neighboring states like South Dakota, where there are indigenous groups that have very high rates of substance use, as well as things like syphilis and HIV, because again, these things go together. And that is in a different way than the ADHD that Dr. Bennington talked about, not something that somebody chose to have disparities put on them. It is something where we can try to be, do our little bit to be part of making it better, hopefully. So. Okay, and then this is another one that also came up in clinic somewhat recently, and this is more of an acute presentation, and just so people are aware of this, because might seem a bit dated, but it's still ongoing. So, patient's a 58-year-old man who presents to the ER with dizziness, fatigue, headache, and shortness of breath. If you ask him, he identifies as a gay man. He was brought in by a friend, and they were at a sex party. Very open communication, which we appreciate. He started to feel bad, and he didn't look good. So his Good Samaritan friend stopped and was like, "Come on, let's get you in and get you to the rural ER here." And he helpfully brings in a bottle of this leather cleaner and says, "This is what we're using." So he looks cyanotic, he's tachycardic, and then you're like, "What's this?" And you go to Google it. Your nurse pulls some blood and hollers over that the blood looks like the chocolate fountain at her son's graduation. And you're like, "That's not how blood is supposed to look." For quadruple word score bonus points, can anyone put in the chat of what the treatment is? And then I see a comment in the chat, and so I will probably skip one or two of the next cases so we can talk about that. And give it a couple more seconds here. A clue is that the treatment has the word blue in it. This is getting back to some toxicology. Again, we're probably not going to see this in the emergent setting. There can be some long-term cognitive effects. Well, then Dr. Massey has sent me a message, so he is corrected as methylene blue. And Denise gets it too. So congratulations, you win eternal fame and fortune. Fame and fortune not guaranteed. This is methemoglobinemia from poppers or an amyl or alkyl nitrite. And these are used as they're one thing that can be used as what may be termed chemsex or using chemicals to enhance one's sexual experience. Alcohol and stimulants and cannabis are also very, pretty common with that. at high acutely, this can cause methemoglobinemia, which can cause hypoxia, and it can be fatal. They're called poppers because they used to be in little ampules that you had to crack open, they're still called that, even though it's not the case. And kind of like kratom and tianeptine, aka gas station heroin, and synthetic cannabinoids, which have been the subject of some bills this year, you can buy them all over the place, and they are not really regulated. They might have different names. And again, it's like, oh, this is a room deodorizer or leather cleaner, and everybody knows what it really is. But this is like, oh, it says leather cleaner. You can't sue us. We had no idea somebody would, even though that picture I found was from poppers.eu, where it's like, okay, everybody obviously knows what this is. So, maybe somebody might be unintentionally poisoned. Usually, somebody would know what these are, but people may not have any idea of all the bad stuff that can happen. And there has been an FDA warning about this. And again, if we think somebody is having issues with this acutely, they need to go to the ER right then to get methylene blue. Long term, there can be some neurologic consequences, and so talking with people about harm reduction would be the thing to do. So, well, then in the chats, let's ditch my other cases and with our last few minutes talk about this. I have a patient who's been using large doses of kratom extracts. We've tried low dose Suboxone and then buprenorphine or Subutex. Patient had a rash with both of them, no residential treatment, not open to treating underlying anxiety and uninsured. So that's not amazing. But so my thought would be I don't know how likely it is to be successful if we try topical or the Butrans patch, if that might be a consideration to see if that does not cause the rash, bypassing the enteral metabolism completely. If the patient's open to it, that could potentially be helpful. Worst case scenario, I think the rash would still happen. I think it's going to be hard to wean down because of kratom's half-life and the variability of potency. Like it's with many non-prescription things, you just really are going to have a hard time knowing what you're getting. Um, Unlike with documenting ADHD and then treating with stimulants, I am not sure. I think that the legal foundation of trying to use traditional opioids and then backing that down would be a bit more challenging, but that would be a consideration. Brooke, is the patient using it to treat pain or mood, or can you tell us a bit more about or is that all about his anxiety?
And Alex, I wanted to add on there too, for with the rash. Um, Another option too is, because this can be with opioids in general, with the histamine response. So the rash can occur, and it can be, kind of a pseudo allergy. One thing before you even stopping it, you could even try like antihistamines, and you can even try topical steroids. I've seen success with, and generally it goes better. It gets better, but if it doesn't, then it, remaining on that if it successfully eliminates the rash. And so would need a little bit more information regarding the rash itself, but I would try to treat the rash first before coming off the Suboxone for kratom, because yeah, there's really no options available for kratom. It's a tough one, and honestly, a lot of times it's even harder to navigate because it's kind of this dual mechanism of action of a stimulant and opioids, and it's very, very difficult. And so that's Suboxone has been the only thing that I've successfully been able to get patients off kratom with. So long story short, I would probably treat the rash.
Well, then, Brooke, anxiety with a stimulant seems a bit counterintuitive. I don't. A lot of times, if people have undiagnosed ADHD, that can manifest with anxiety. And maybe Will, I don't know if you can connect Brooke and probably Stephanie. I think she'll be more helpful than me for Brooke. But what do you think about maybe using either a Vyvanse or a Concerta if you talk to them and and it does sound like that's plausible, and we do the self-report, like, would that be a viable strategy if this patient screens positive?
Yeah. Yeah. So I always say this to people when especially when patients present with anxiety. And we do have a positive scales for ADHD. The stimulant's going to fix their anxiety. So we don't least amount of medications possible, and a lot of times it interferes with, it prevents full absorption of the stimulant. So we treat the stimulant, and we still have some anxiety, increase the stimulant because their anxiety is going to get better. There is the population of patients that do have a co-occurring primary anxiety disorder as well. And that would kind of be able to discern between the two. And then you would treat that separately. For kratom is its own different field. The anxiety associated with kratom is tough. Our common anxiety medications don't really touch it because we got this dual mechanism of action, and they're trying to navigate their dose. They're not doing well because they just don't want to feel so crummy. And so with that, once they get to high enough doses, the anxiety is terrible. I mean, it's debilitating. The panic attacks, they have this kind of the panic attacks kind of cause like even cognitive impairments associated with the kratom. So I actually end up just going to antipsychotic during that. If it's so bad that it's interfering with our treatment, I load them with an antipsychotic, make sure that, and I typically use Seroquel to make sure we're sleeping. And I do it for just about a week so that we can initiate the Suboxone, and then I take them off of it. And it's usually enough to kind of get us through that initiation period.
Excellent. Thank you. Thank you, Stephanie and Alex, for the cases and your expertise. Those are awesome. And thanks, Brooke, for bringing up a case today. We always appreciate when our participants bring up those cases. That's great to see. So we're at the end of our hour here. I dropped a link in the chat. If you want to claim your CME certificate, you can go do that quick. I'll also email that out. And we'll be back on July 18th. In the meantime, yeah, feel free to reach out to us if there's any consultation, discussion of patient cases. Our experts are always happy to do that, so don't hesitate to reach out. Thank you.
And
then
I just
Echo,
want to kind
go
of
ahead.
repeat what
Yeah,
Will
go
said.
ahead.
Really encourage if there's ever cases where it's like, I would appreciate just kind of somebody to kind of navigate, just to listen, just to, just another ear to kind of give what they think. Just to send an email to Will, and we'll typically get back to you within an hour to 2 hours, but we typically respond quite quickly to make sure that you can we can discuss this and get the patients the care that you're kind of thinking. So please use this resource. It's free to you. We enjoy it. We're here for you. So just let us know.
Absolutely. Thank you. Yep. So we'll call that a day. Echo team, if you want to jump over to that other link for a quick team meeting, we'll see you over there. Thank you.